Yeah.
Madam, we are live. You can start.
Yeah. Good morning, everyone. In continuation with our male infertility topics, today's topic is assessment of sperm morphology. As we all know, like we classify the male into fertile or subfertile or non-fertile by various parameters. That is the basic parameters like sperm concentration, sperm motility, and morphology. So in this, I think sperm morphology is something which we don't really give it much importance till date, where we, as much as we give it to the count and the motility. But I think morphology is equal or sometimes more important than the motility and the concentration, which Dr. J will throw more light on today, because I think he is one person who has studied this in depth and has immense practical knowledge and practical application as to how we can use it in our IVF or even our regular infertility practice. Yeah, over to you, sir.
Okay. So I will start with the screen sharing, Shilpa, madam. Just
Yeah.
stay online. Okay. You can see my screen, right?
Yeah.
Okay. Fine. So today we are going to be speaking about the morphology of the sperm. All right. Now, one important thing which people should understand as far as sperm morphology is concerned is that this is only a morphological assessment. All right. This is only an assessment of how the sperm actually looks. All right. So just to keep this in mind, you must remember that the best way to study the how the sperm looks is basically by doing transmission electron microscopy, which is TEM, which is absolutely impractical to do in a routine setup. All right. One cannot really end up doing that in a routine setup at all. At all is the word. Okay. So ignore that. What we are trying to study basically, as far as the sperm morphology is concerned, is something on slide preparation, okay, and staining. Slide preparation and staining of immotile sperms. Okay. This is something which we normally study. Obviously, there will be certain people who will add computer assisted semen analysis algorithm, which is a software, in order to have better accurate detection of sperm morphology. Otherwise, in more than 99% of the places, sperm morphology is a manual assessment. And the biggest problem is this manual assessment is only done by 100x in oil immersion. Routine people will do it only in oil immersion, as a result of which, out of the 99% of the people who do it, 99% of the reports are erroneous. All right. This is something which you have to keep in mind, because the best way to study the sperm morphology is actually not like this, is actually to study it on an ICSI microscope. Okay. And the ICSI microscope will offer you a magnification of approximately 400 times. You want to go one step ahead, you can use the IMSI lens, and IMSI is basically a software. So I will just write down the IMSI software, which allows you approximately 6,600 times. Okay. But see, I have the IMSI, and I will tell you that for a routine purpose, it is an absolutely waste. Okay. At one point in time, because I was doing a lot of IVF cycles, especially male infertility cycles, and we were having a lot of workload of poor sperm morphology, we thought we will invest in IMSI. Okay, that is the intracytoplasmic morphological assessment of sperms, and then injecting them. But we have realized that it is a waste. Okay, so the 16 lakh rupees which we spent at that point in time on a software called Octax has not really helped us. Okay, it is a waste in my humble opinion. But people who have excessive money, they can probably donate some of this money to Shilpa GB. She is so active in stock market, she'll double it for you. Okay. So coming to sperm morphology, just remember one thing. All right, 90% of this morphology, okay, is in the sperm head. This is what really, really matters, because after the sperm reaches the oocyte and reaches the cumulus of the oocyte, it is important that this shape of the head is important. It is this shape of the head of the sperm which decides the acrosomal reaction. Okay, it is here. The Golgi apparatus is located on the top, which forms approximately 60 to 70% of the cap, and that is the acrosomal reaction. And this acrosomal reaction is absolutely mandatory for any form of fertilization to occur. Obviously, you have a lot of mitochondria scattered here in 3D through the centriole, and then you have the axis which is going inside the tail. So we are here not going to talk of abnormalities, predominantly which are unimportant. For example, if I tell you that there is a double tail, okay, this double tail is not going to be present in 100% of the sperms. If I tell you that the width of the mid piece is higher than normal, that is not going to bother in more than 80% of the sperms. Okay, there is going to be some tails which are going to be smaller, so that is not going to affect the motility of the sperm. It is going to affect the morphology, not the motility of the sperm. All right, what is difficult to understand is the only abnormality which we should remember in, which is clinically significant in the region below the head, is this. Okay, here in the neck, if we have something called as a bent neck, okay, there is no fertilization. Just remember that bent neck is a direct indication for doing ICSI. There is no fertilization which occurs in all these things. Thick middle piece and thin middle piece has got nothing. Okay, the only thing which you should remember as far as the tail is concerned, as far as morphology is concerned, okay, is if it is a short tail. See, if it is a very short tail, then it can indicate three things. It can indicate necrospermia. Okay, it can indicate akinesia disorders, or it can indicate dead sperms. Okay, all the sperms are dead sperms. Remember one differentiating feature of asthenozoospermia. When you have something called as absolute, that is 100% immotile sperms. In 100% immotile sperms, which is called as absolute asthenozoospermia, okay, we see approximately 2 to 10 cases like this every year over the last 7 to 8 years. No motility in the tail. All right, in that the tail length is normal. Okay, tail length is normal, and in that situation you need laser stimulation of tail. Laser stimulation of the tail plus ICSI, and it works beautifully well. Okay, so these are the only two things which you need to remember. Forget all the other anomalies. All the other problems are going to happen as far as the head is concerned. Okay, and when you try to look at the head of the sperm, remember one thing. It is the shape which is very, very important of the head. Okay, this shape of the head is very, very important. So all the other shapes which are abnormal, okay, globe, ozoospermia, pinheads, it's a very common thing, okay, to have pinheads, small heads. And if this is present in more than 99% of the sperms, okay, then it is a direct indication of ICSI. Because remember, all this abnormalities, when they are present in more than 99% of the sperms for anything, then they are classified as systemic abnormalities. Okay, that means there is a testicular problem only. Okay, all the other problems which happen, this there is a large vacuole which is present. Okay, all the things which happen inside the nucleus, okay, vacuolated nucleus, and large nucleus, round head, this, that, all these things, vacuolated is the most common thing which you find. This is all going to be due to external causes. How do you identify if it is a vacuolated cause? The only way to identify it is on an IMSI microscope. Okay, otherwise you can't really identify it easily, and even if you identify, it will be wrong. Vacuolated thing is related to a high DNA fragmentation index. It is something which is correctable. Okay, it has correctable factors. You can give antioxidants plus lifestyle changes. Okay, plus endocrinological problems if there are any, and you can probably correct it. But remember, everything else which you study as far as the morphology is concerned, if it is going to be more than 99% sperm of the same type, then it is going to be a systemic cause. It is also extremely important for people to remember. I will try and show you this image. Okay, that as far as the standard criteria of sperm morphology is concerned, okay, when you look at all the standard criteria of sperm morphology, you just need more than 4% sperms to be normal. All right, see, once upon a time when this criteria was made long back, okay, initially they were saying that more than 15% sperm should be morphologically normal. Then they cut it down to more than 4% should be normal. So it indicates that our testis as such produces a very high amount of abnormal sperms. Okay, and this is when you are looking at strict criteria. Okay, So this strict criteria, no, don't try and implement it on your own. When you try to implement strict criteria on your own, it will take minimum, okay? It will take minimum of 2 hours to study 200 sperms. We try to normally do a morphology report by studying at least 300 sperms, nothing lesser than that. So do not try to put inside any of these criteria in your mind that I will go by strict criteria and strict told this and strict told that. Strict does not really help you in practical life situations. Just remember that. In practical life situations, person will realize that there is an abnormal sperm morphology only if you have asked for it. Okay, for example, there are multiple IVF failures, recurrent pregnancy losses, multiple IUI failures for that particular patient, or unexplained infertility. The same criteria which you follow for abnormal DFIs are the criteria which you will otherwise end up following for a abnormal morphology. There is nothing that I have a complete report which states that sperm morphology is good. If your sperm morphology report is a single page report, that means it is a wrong report. Okay, I will show you how the sperm morphology report actually looks like. All right, just see this. This is how your sperm morphology report should read like. Okay, the total number of sperms, the percentage of sperms evaluated, number of sperms which are normal inside it, number of sperms which are abnormal. All right, how many defects were calculated? Head defects, neck defects, piece defects, all these things, sperm deformity index, Teratozoospermia index. Okay, all these things will be answered in that. But it is important that this comes along with the picture. Can you see this? Now, this is the arrangement of the slide. Now, this is the arrangement of the slide, which is then studied by CASA, that is your computer assisted semen analysis algorithm. And you can see there are multiple sperms which are overlapping each other because the sperms are not going to be on a flat line. Some sperms will be below, some sperms will be above. Understanding? So it is this algorithm which ultimately goes and calculates which are normal sperms, which are abnormal sperms, and you will easily understand. Okay, if I show you what is an abnormal sperm, see there is one sperm which is mentioned here in the corner, which is mentioned as an abnormal sperm. The reason why this is mentioned as abnormal is because there is hardly any middle piece. Can you see that? Hardly any middle piece is present inside this sperm. Okay, that is considered to be an abnormal sperm. The algorithm itself is such that it will calculate. And see, in this entire slide, so many sperms are abnormal. Only one sperm is normal sperm. I am pointing towards that and showing you that normal sperm. The reason why it is normal is because the graph has not picked up anything. Can you see the head? Then there is the middle piece, and then there is a beautiful long tail underneath that. Can you see that? So because it has picked up something so nicely, it has reported this to be a normal sperm. Otherwise, everything else where the head is small, head is large, head is abnormal, tail is abnormal, everything else is calculated as an abnormal sperm. And when you have an abnormal sperm, it will immediately report it to be an abnormal sperm because it has a fixed diameter as far as the algorithm is concerned for this head. Can you see this white colored diameter here, which is getting shown on the slide? This white colored diameter. So if your sperm, which is well prepared, is fitting inside this white colored diameter, that means it is a normal sperm. Baat khatam. Okay, obviously, one can go by this prefixed criteria, which are the best things to go through, because otherwise analyzing these type of sperms is going to become very difficult. All right, coming to something important. Okay, we have diagnosed the sperms are abnormal. Now what? Okay, so if you have diagnosed multiple anomalies inside a sperm, okay, we normally see reports which are stating from many of these patients who go to these free IVF clinics, no? And when they go to these free IVF clinics, there is free semen analysis. In that free semen analysis, everybody will have only 2% normal sperms. Understanding? Everybody will have only 1% normal sperm. How is that possible? Tell me. Okay, how is it possible that entire Bombay is producing children with abnormal sperms? How is that possible? So that is not possible, right? Humanly, it is impossible to do something like this. The minute you repeat this, see, the best advantage of having free IVF clinics everywhere is that there has to be one clinic which is properly charging. Understanding, then all the patients come with this semen analysis report and tell you, sir, my sperm is gone. You know, nothing is going to happen to me. You just ask him to repeat the semen analysis report, and suddenly he will become Shahenshah. You know, from 2% normal sperms, suddenly that sperms will become 18% normal sperms. The reason why it becomes 18% normal sperms is because he gets a 20-page report with it. Understanding? Because it is a computer generated calculated report. Okay, so please note what we are trying to project. Majority of the people which I see in a fertility clinic, in my practice of seeing 5 patients in a day, everybody has abnormal sperms. No, it is not abnormal sperms, it is wrongly reported. I am telling you, trust me. Okay, every year when it comes to globozoospermia, pinheads, necrozoospermia, short tails, these are not very common cases. It is not very common to find these type of cases. Believe me, when you find these type of cases in your clinical practice, remember, because they are systemic causes, they are going to be very difficult to treat. Okay, it is very difficult to achieve a good fertilization. Everybody needs ICSI, and it is very difficult to achieve a good fertilization and a good blastulation rate in a systemic cause of abnormal sperms. All right, lot of times people will say that initially my sperm morphology was 3%. I took antioxidant, I took it for 3 months, and now my normal sperm is 30%. It's not possible for that to happen. It is nothing to do with antioxidants. All right, it is simply an erroneous reporting. So please keep that in mind. Okay, I will give you a simple example. See, we take approximately 7,000 rupees for reporting sperm morphology. Okay, just to report sperm morphology. Majority of the people will do it for free. Correct? How is it possible that your slide, the slide kit to report the morphology itself, okay, you have a proper slide and you have a kit to prepare that slide in order to cause the sperm to become immotile, then the sperm has to be layered, and then you apply IR over it, that is infrared light over it, and then you are studying it in CASA. Correct? How is it possible that the kit itself, which is costing 250 rupees, okay, is being given to free for anyone? Right? If you are a big time Dayavan, then you will do it at 251 rupees. Understanding? But how can you do it for free? It is not possible. All right. So the reporting which happens for sperm morphology for free is usually an erroneous reporting. Nothing is given to the patient, only one small handwriting is written, which the fertility consultant will take a beautiful highlighter and mark. Your sperm is only 1.1%. Very bad. Come for IVF tomorrow morning. All right. Tomorrow morning he will come, but he will come to some other clinic. Understanding? To verify if that information which is given to him is correct or not. Okay. And remember, it only happens in India. All right. Only in India, everybody has 1% normal sperms and 1 children. How? In all other countries, why are you laughing, Dr. Shilpa?
I'm sorry. I'm sorry. Yeah, please continue. I'm sorry.
Yeah, no. And only in India this happens because of a little abnormal abuse of antioxidants. Okay, sorry, I'm just diverging from the topic, but this is important. Okay, there is just one thing which I think has helped some people as far as improving their morphology is concerned, provided the morphology is genuinely in that range of 5 to 7%. And that is, in our country, 2 things which you must keep in mind as practicing clinicians. One is obesity and second is diabetes. Okay, these 2 things are correctable factors, and the third correctable factor is varicocele. Okay, I'm probably going to take a masterclass on varicocele if Shilpa madam allows, because it is one of the most abused surgeries as far as andrology is concerned. Okay, if you speak to an andrology specialist, the genuine ones, okay, they are going to tell you that varicocelectomy has a very limited role in male infertility. Okay, you can't really have a patient with obstructive azoospermia with varicocele and you repair the varicocele and the obstruction goes away. Okay, simultaneously vein will also get obstructed. That is what people should realize. Okay, because you are causing varicocelectomy is obstructing the vein. Understanding? But this is a concept which people should understand, that morphology may improve if there is a bilateral palpable varicocele. Okay, sperm counts are otherwise normal, but the patient is associated it with high DNA fragmentation and abnormal morphology. In that situation, varicocelectomy will help. Probably if Dr. Shilpa agrees, then we will have a session from Dr. Alap Mehendle, who is an excellent person in doing microvaricosilectomies, and he's done quite a lot for us as well. And people have had excellent results. So when I mean excellent results, it is in the tune of 25 to 30%. That is a part of his counseling. It is not 100%. Okay. So just keep that in mind. All right. One more thing which I wanted to mention about morphology, okay, is a lot of times, okay, the biggest problem is, I am again repeating this. A lot of times the biggest problem is morphology is not even reported by oil immersion on 100 times magnification. People just do the macular chamber, okay, and report it in 20 minutes. The slide preparation for morphology takes 1 hour. Okay. How can you assess the morphology before the sperm has liquefied? Tell me. You can't look at the semen sample and say, 93% abnormal. How can you say such things? Understanding. So please keep that in mind. Morphology is a game of technical analysis. Okay. Though technical analysis is related to stock markets, this is a technical analysis of the sperm. If you are having a good technician to have a good slide preparation, okay, then your morphology reporting will be very much excellent. And the best is to report it on an ICSI microscope. Okay. This is just my inputs on this. I will be happy to answer questions from Shilpa madam on this.
I think you're in full form, like Indian cricket team who entered finals. So thank you very much. It was excellent. So tell me, I mean, having a normal morphology or an abnormal morphology, has it got more of negative predictive value or a positive predictive value, or no predictive value?
It's very difficult to predict that, madam. It's very difficult to predict unless you have a systemic abnormality. You know, for example, Globozoospermia, you know it is going to be an infertile male. Okay, but a male who is having vacuolated sperms, you don't really know if this vacuolated sperms will give rise to an abnormal embryo or not. Right? So there is no such thing. To be very honest with you, there is no such thing.
Okay. So, see, like all it takes is 4% normal morphology sperms for a man to be classified as a fertile. Okay.
Yeah.
Just that 4%, is it the percentage which is important, or is it the number of normal sperms? So, like, say, if you have 15 million count and 5% normal forms, or you have 25 million count and 3% normal forms. So, do we really, like, I mean, give the importance for the percentage, or should we just go by the count to the percentage thing?
Madam, honestly, both of them don't matter. Because when you are trying for a natural intercourse, okay, it is important to understand that if these sperms are genuinely abnormal, then 90% of these abnormal sperms will be restricted by the cervical mucus only. The cervical mucus is such that when you are trying for a natural intercourse, the cervical mucus itself will prevent majority of the sperms from going up. Okay. That is something which people should keep in mind. Okay. As a result of which, a lot of people try and say that, we should do IUIs for sperms who are having a high, Teratozoospermia and all these things. But the answer to that is actually it is not a genuine teratozoospermia.
Your voice is gone. Sir, your voice is not there. We can't hear you. Yeah.
Yeah. So if it is a genuine teratozoospermia, then even IUI is not going to work. That is important for people to understand. Okay. Because people wrongly associate it with IUI and say that, see, he had abnormal sperms and I did IUI and something happened. Actually, there is nothing like that which happens.
So you said in absolute Teratozoospermia, you have to stimulate with laser for the, I think for the tail.
For the tail to bend, madam. The tail has to bend.
Yeah. So for that laser, you use the same laser which we use for assisted hatching?
Same laser, madam. Just reduce the pulse. The pulse of the laser which we normally use is going to be at between 80 to 120. Okay. When you are using the
I think your voice just went off. You have some network issues, I think, sir. Can you please check?
I don't know, madam. I mean, here it is showing everything is good, even on Wi-Fi.
Can you please tell that again? The laser pulse has to be reduced?
For laser stimulation of sperms, you have to reduce the pulse to 50 microns. Okay. For routine embryos, it is between 80 to 120.
Okay. And there are only two morphological problems that you will advise ICSI directly. That is, one is the bent neck and the other one is absolute asthenospermia. Is that the final thing that you would want to say regarding
No. I said for any systemic abnormality, globozoospermia, pinhead sperms, bent neck, abnormal tail, short tail. These are all systemic abnormalities. In systemic abnormalities, if more than 99% of the sperms are with the same condition, okay, let's say more than 99% of the sperms are having globozoospermia, more than 99% of the sperms are having pinhead sperms, more than 99% of the sperms are having a short tail. Okay, in all this situation, ICSI is the treatment of choice directly.
So you are saying that 99% of abnormal sperms are the indication rather than we concentrating on that 1% normal morphological sperms. You mean that?
Definitely. Yeah, definitely, madam.
So 4% is the normal. So if the morphology is like 1% normal, then you advise them to go for ICSI.
ICSI, straight away.
Okay, and like you do on CASA, so we all know that. So what would you suggest for people who are doing it manually? See, I don't think everybody can afford the 20 lakhs CASA machine that you are having. So for routine fertility clinics or who don't have the IVF facility in their center, so what is the best that they can do at their level?
The best that they can do is assess them on an ICSI microscope, as I mentioned. This ICSI microscope will help you get a good idea of the morphology of the sperms. You might not be 100% accurate, but your broad picture about it will be very good, madam.
Yeah. So if the ICSI machine is also not there, where we study under 400 magnification, so what is the next best thing?
100x oil immersion, but the slide preparation for that has to be very good.
Okay, so I think we request you to at least show us one slide preparation whenever you find time, so that we all can learn from that. So I
Sure.
think it was excellent practical aspects of morphology. I don't think anyone has spoken for half an hour on morphology alone, but I think this was much needed. Since we see a lot of reports wherein they come with a report saying that 2%, 1%, 3%, and like the men are literally like fidgety and they want to prove themselves or their masculinity or whatever you call that. So I think this adds a lot of value for us in our day-to-day practice. Thank you so much. Thank you. Have a good day, everyone.